All right, well, it's 12:30, so I think we'll get started. I'm sure that there'll be other people who join us. I can see that other people are joining us now. So welcome everybody to March's qiCommunity webinar. Today we are very excited to have Paul Tait, a Lead Palliative Care Pharmacist. Paul is the Topic Coordinator of Medications and Ageing at Flinders University. He has published widely with a focus on the timely access to medicines for community-based palliative patients. His areas of interest include patient safety, quality use of medicines, and medicines information. And of course, as well as Paul today, we have Dr. Tony Lemke, who is the chair of qiCommunity and is a very busy GP at the Alstonville practice in North Coast, New South Wales. So welcome, Paul and Tony.
Yeah, welcome, Sarah, and thank you very much. So it's Tony Lemke, as Sarah said. I'm a GP in Alstonville, New South Wales, where it's always sunny, and it's particularly sunny today. We remember those people in places where they've been devastated by the bushfires this week and send out our thoughts and prayers to them. I'm joined today by Paul Tait. Good morning, Paul.
Good morning, Tony. Good morning, everyone.
So thank you for joining us, Paul. We're going to be talking about managing medicines in palliative care during the last days of life this morning. Now, Paul, this really is a major point of activity in primary care. It's a common problem.
Absolutely. I thought I might just start with a little bit of a background to where I've come from before I leap into the conversation around palliative care. 6 years ago, I was working in a neonatal intensive care unit as their ward pharmacist, and I found myself talking with the director of a community palliative care service in the south of Adelaide about joining her team. And for me, it sort of was very exciting opportunity because the project itself was very strategic and looking more broadly than just the acute healthcare centre service, and looking more into primary care, which of course has a whole lot of other challenges with it. So building on what you said about palliative care being a common issue in the community, certainly the Grattan Institute published a report a couple of years ago that estimated that there were around 100,000 Australians that would benefit from palliative care services. And so I guess you could argue that many of them would access those sort of services in an acute hospital context. But to be realistic, someone in the last 12 months of life are going to spend a bulk of that time in the community. And so while there are specialist palliative care services working in the community, it will involve engaging with other community services, including GPs like yourself, Tony, but community pharmacists and community nurses as well.
Paul, we have to stage where most people die in their, I know that people often express a wish to die in their own home. Some people manage it. That's not universal.
That's absolutely right. In fact, there was a study done in Adelaide maybe 10 years ago, a decade ago, that suggested that if someone had a life-limiting illness, that 70% of people would wish to remain at home. But we know that the numbers are nothing like that. In fact, the Grattan report that I referred to in the previous slide actually tries to break that down across Australia, and it shows that about half of all Australians will die in a hospital context, a third of them will die in an aged care facility of some description, and only about 14% of them die in their own home. But we do know there are some facilitators for people being able to remain at home to die, and that is having an advanced care plan, having a full-time carer in place. A GP is paramount, of course, but also having good symptom control. Once you lose the ability to control someone's symptoms, that's when people tend to escalate care.
And symptom control in palliative care is dependent on a lot of factors, but a significant proportion of that is related to medication and pharmaceutical use. So I guess the role of community pharmacy for those patients in the last days of life can be really important.
Absolutely, it makes absolute sense to obtain medicines as close to home as possible. And it's interesting, if I talk to a group of professionals who are working age and ask them if they use a routine pharmacy, you might find a few hands go up in the room. But certainly when I talk with my palliative care patients and ask them if they have a relationship, an ongoing relationship with their local pharmacy, about 85% of them will say, yes, we've got a connection with that pharmacy. And I think that's an interesting insight, and it gives us some clues about how we can manage this group of patients as they deteriorate into the last days of life.
And I guess it's important, Paul, that most of my interaction with community pharmacy is about pill-based oral medications, but in palliative care, when I think about my palliative care patients, it's often enteral or injectable medications we need, and they're often at random times of the day. It can be hard to have, I imagine as a pharmacy, it's hard to have stocks of everything one might need.
Absolutely. So just to give a bit of background, when I first started in this role 6 years ago, I had a good heart-to-heart with my new boss, and she gave me an interesting case study of a complaint, really, of a fellow that was about my age, caring for his mum, and she had recently lost the ability to swallow, and so therefore she wasn't able to take her oral medicines. She was clearly totally bedfast as well, and needing round-the-clock care. And the GP was able to do home visits and assess Claire as being in the last days of life, and prescribed what, on the surface seems quite reasonable medicines for nausea, agitation, pain that she would have been experiencing. But you can see in this list that they were all injections. Now, interestingly enough, and this is where the complaint came, is that the son, Mark, he actually drove somewhere in the vicinity of 30 kilometres throughout metropolitan Adelaide, which just makes me sort of gasp, actually, trying to locate a pharmacy that stocked each of these medicines. And I guess this is it started a bit of a conversation within our unit about how big this problem is in terms of accessing medicine. Some people might say that this is an extreme example, but as I go through the talk, I'll be able to talk a bit more about some of the findings we've had across South Australia at any rate.
So if we move to it doesn't sound like an extreme example, Paul. I can imagine that would be a fairly common example as people move into that terminal phase of their palliative care and can't swallow.
Yeah, well, the trick is that while we know the punchline with this group of patients, we know that they're going to lose the ability to swallow and that they're going to have to move over to injectable medicines or subcut medicines. The deterioration can sometimes be quite rapid and catch people by surprise. So there are some things that we do know, though, and that is that there is a small range of symptoms that you can anticipate, which you would expect to see in the last days of life. Now, not every patient would experience all of these symptoms, but they include pain, nausea, dyspnea, noisy breathing, or the death rattles, and delirium have been reported. Now, if you unpack the therapeutic guidelines, the Paliative Care Therapeutic Guidelines, which are your standard text in Australia, you could actually count the number of formulations available to manage these symptoms that are either subcut injections or oral liquids. And it comes to about 35 or 40 formulations. And you could say, well, actually for a tertiary level hospice, that would be reasonable for them to hold that on their imprest. But for a community pharmacy to stock a range of 35 to 40 different formulations, just in case, that seems quite unreasonable. So you can understand sort of where Mark got into trouble with accessing the medicines to help his mum stay comfortable. So that led us on to a study that we did. It was a survey-based study, and we basically sent this off to about 450 pharmacies across South Australia. And so what I'm going to do is just talk briefly about what the survey was about and some brief results. But I just want to stress that while the study was conducted in South Australia, whether you're a GP in Burnie, a pharmacist from Canberra, or a nurse from the Mornington Peninsula, I think you'll find some similarities and some common issues that are across your practice to what we found as well. So effectively, we developed this survey by looking at the range of medicines that we issued on discharge from our hospice that related to those symptoms that I talked about earlier, so pain, nausea, and so forth. And so we came up with a list of 13 medicines. Now, of course, there is a longer list. We decided to abbreviate it down to this list of 13. As well as asking whether the pharmacies held these medicines, we asked about the demographics of the pharmacy and the types of services that they offered. We asked them about if they were aware of palliative care patients using their service, as well as the availability of these terminal phase medicines. We asked about the expiry dates of these medicines, whether they were imminently going to expire on the shelves of the pharmacies, understanding that they're businesses. And then the final question was really whether or not, how they would respond if they received a prescription for these particular formulations, and just to get a bit of an understanding of the community pharmacy's perspective. We also threw in a little checkbox to whether or not they wish to sign up for a monthly newsletter as well. So the results were very interesting. We probably got feedback from just over 100 of the pharmacies, which is almost a quarter of the pharmacies across the state, and 40% of them were from rural areas, which we were very pleased, because actually we found some interesting differences between rural and metro parts of the state. Interestingly, 13% of the respondents were unaware of palliative care patients using their business over the previous 12 months. Which is actually quite damning, really. You know, we live in a world of where communication is really important, and for 13% of the respondents, they felt like they were outside of the loop. The pharmacies actually held a median of 3 out of these 13 formulations from the list that we put out. And then to the next slide, 21% of respondents learned about palliative care patient from another health practitioner. And this was a really interesting point, because it turned out that this 21% actually held a larger range of medicines than the remaining respondents who hadn't heard about it from a healthcare practitioner. And this also speaks, I think, about communicating about the patient's needs with the community pharmacy at the end of life. So if we move to the next slide, we've basically got a graph here, and this shows really the outcome of the proportion of pharmacies that held each of those 13 medicines. So the y-axis, 0 to 100%, just shows the proportion of pharmacies that actually stock the medicines, and the x-axis from hydromorphone through to the metoclopramide actually shows each of the 13 medicines. And you can see a few things from this graph. First of all, the most common medicine held in community pharmacies was metoclopramide injection, which is interesting that it wasn't 100%. It was sitting around just over 70%. And I say it's interesting because metoclopramide injection is in the doctor's bag, so it's something that you would expect a reasonable amount of turnover of. There were also, the other interesting part of this graph is that there were no medicines that we inquired about that were in 100% of all the pharmacies. The next slide talks about the expiry dates of the medicines. And so on the y-axis from 0 to 60 is looking at the months to expiry of the medicine. And I've just reversed the order of the medicines on this graph, but the x-axis just lists those same 13 medicines. Now, the positive part of this graph is that the red triangles show the median number of months to expiry of each of the medicines, and they are sort of sitting in a comfortable range of 12 to 24 months. But the bars actually show the maximum expiry and the minimum expiry. And what I like to do is point out that there were many pharmacies that were imminently about to throw stock out because they were about to expire in the next few weeks. And I say that this is a really important issue because actually as businesses, community pharmacies will then have to make a decision, a business decision, whether it's worthwhile holding on to that medicine again, like restocking it. They would wear the cost of that, but whether they reorder it will be up to the philosophy of the pharmacy. So just to finish up with our study, we really learnt that there were a broad range of medicines available in Australia. And I guess if you think about each individual prescriber having their own habits around what medicines they like to prescribe, community pharmacies were unable to anticipate the range of medicines to stock. So GP A and GP B may have different opioids that they prefer. And then the community palliative care service might come in and they might have an alternate opioid that they use as well. So the community pharmacies in the survey were getting mixed messages about what to stock. The other insight was that there was a clear link between those respondents with some sort of clinical information about the patient, so understanding that someone had palliative care needs and holding a wider range of the medicines, which we found really useful.
So Paul, on that issue then, and if I could ask you to just draw a couple of things out, only 20%, 21% of pharmacies were notified by anybody that the patient was on a palliative care pathway, which is extraordinary, isn't it? And I can see that reflected locally, but so most of the pharmacists had no real contact to let them know that patients that they look after were imminently becoming palliative care. And as you've already pointed out, the terminal phase of palliative care is predictable. One can see the need for better communication between the general practitioners, the family and the pharmacy about people's trajectory, allowing them to prepare.
And the other part of that equation is that many of these patients already have an existing relationship with the community pharmacy. So, you know, to me, it's a case of picking up the phone and having a quick conversation with them. It's not about developing an ongoing, you know, setting up a relationship from scratch in many cases. So to me, it is surprising, the results, but actually, I think there's good information that we've gathered to show that it would be reasonably straightforward to rectify, if that helps. So one of the, you
did mention, Paul, there's a difference between rural pharmacies and urban pharmacies. Did you want to tell us about that?
Yeah, just quickly, we found we've done this survey twice, and I'm only giving you the results of the first round of the survey just to show how we managed this problem. But just briefly, we found that the regional pharmacies, those in rural parts of the state, actually held a broader range of the medicines. So while I said the average pharmacy held 3 out of 13 of the medicines that we asked about, a rural pharmacy held 5 out of the 13 medicines that we asked about. And, you know, while it was difficult to unpack how that happened, I know from my own experience working in Broken Hill, for instance, that, you know, I was on the same volleyball team as the GP. And you know, I think that communication was a lot easier in that context. But you could also argue that, you know, the accessibility to transport and getting the medicines in was going to take longer. So, I mean, I remember a couple of nights where I stayed back to meet the aeroplane coming up from Adelaide to make sure that we had the medicine for the person the next day when I was in Broken Hill.
So then, having done the survey, you look for some solutions to help with some of these supply issues, and you thought about whether all 13 were necessary, and perhaps we should have a standardized list of medications.
Absolutely. So the next slide, I'll step through very quickly. I mean, we know that there's certain things that can, when you're looking at projects at changing practices, things that are really strong at making changes to practice, and things that are quite weak. So something like putting up a fact sheet or an information sheet on a wall is very weak, whereas actually something like a forcing function makes things very strong and you know, guides change a lot stronger. We went down the line of standardisation. So understanding that there's this broad range of medicines that are accessible in the community or available on the Australian market, should I say, but actually you don't need a range of 40 different medicines. We could get away with a smaller range of, say, 5 medicines. And so we developed an expert working group within across the metropolitan palliative care services in Adelaide, and we looked at, for those who are in Western Australia might be familiar with this document that was published over a decade now, that guided the range of medicines to hold in aged care facilities. And we looked at this and looked at unpacking this against certain criteria. Deb Rowett, who some of you may be aware of, has published some criteria around developing tighter lists. And if you go on to the next slide, that just sort of unpacks that criteria. So evaluating against the evidence, comparing the cost of the medicines, looking at the routes, ensuring that we've got subcut medicines particularly, and comparing it with the PBS criteria as well. So we came up with a list of 5 medicines, which includes clonazepam 1 milligram per mil injection, the morphine 10 milligram per mil, haloperidol 5 milligram per mil, metoclopramide 10 milligram per 2 mil, and hyoscine butyrbromide 20 milligram per mil injections. We sent this out to a really broad group of stakeholders, which included GPs and nurses and pharmacists, and we asked them to give us insight into, you know, whether we've got this list of medicines correct, and to provide any literature that might support any changes. We got lots of feedback, but actually no one was able to provide us with literature to argue a different case about these 5 medicines. So they ended up being the 5 medicines we went forward with. And we did a range of different strategies to engage with prescribers and pharmacists, as well as aged care nurses, I should add, including workshops, publications. We published in the Australian Family Physician, newsletters, and CareSearch helped us with blogs to communicate as well. So we came up with this list, this concept of a core medicines list, and throughout this whole project that's run over the last few years, we've come up with some learnings, I guess. So I'm just sort of broken it down to 5 things that I've learned about prescribing in this particular phase of life. So the first thing is we actually know what symptoms can be anticipated in someone's last days of life, and they include things like dyspnea, nausea. We've mentioned them before. So the second thing is then that we can then, from that list of symptoms, come up with a list of medicines that are likely to be prescribed. So for the GPs listening in, this is something that you could relate to in terms of, well, actually, I always use morphine, or I always use midazolam, and so forth. For the pharmacists who are listening in, it may be a case of actually having conversations with the GPs in the area and thinking about the range of medicines that you may need to keep. So if we move on to the next slide, there's actually a whole series of groups around the country, including ourselves, who have either published or put on the internet their lists of different medicines. So for those who are starting out and thinking, oh, I don't know where to start, this might give you some examples of lists of medicines to have in your toolbox, or for the pharmacist to think about having conversations with the prescribers in the area around this range of medicines.
And I'll just point out there that we do have all the slides available in the material section. So that list there is available to everybody. You just need to download from the material section of your chat pane. Sorry, Paul, thanks.
No, that's a good point, Sarah. Thank you. So the third point is to actually document the patient's usual pharmacy, because as I said, these sort of the stepping into the terminal phase can be quite sudden, and even though it can be anticipated, can catch people unawares. And actually having a document in the GP's file that actually says this is the patient's usual pharmacy. We certainly do that in our palliative care service, and we list the phone number and the fax number so that we're able to contact them, and we know that people have already got connections and relationships with these pharmacies, so that works out quite well. The fourth thing that we do is we involve the community pharmacist ahead of time. And I've just put this driver diagram just to show what the sort of thinking of a community pharmacy could be. So they might look at that list that's in the Paliative Care Therapeutic Guidelines and carry a broad range of medicines that are listed throughout the guidelines. But then they run the risk of medicines expiring on the shelf. So in terms of sustainability, that can limit the sustainability of holding that broad range. Alternatively, they can carry no medicines, and then they're waiting for a prescription to arrive, and then that leads to delays in accessing medicines because they've got to order the medicine from their supplier. So by actually making arrangements with the pharmacies in the area, they can actually anticipate what medicines to hold, and they can actually have it there ready to go. I've made a comment briefly here about home medication reviews. So it's not just about the terminal phase that engaging with the pharmacies is important, but maybe when someone is diagnosed with a palliative illness or a terminal illness, actually getting the pharmacy on board months out from their death to actually do a home medication review may actually be quite a useful opportunity to engage with the community pharmacy ahead of time and to acknowledge that they've got palliative care issues. And the fifth point is really just to identify some good dosing resources. And I don't think there's any big surprises in here, but I guess the thing is about getting consistency, about getting familiar with the way the guideline is set up and using that constantly rather than flipping between different resources. So, yeah, I'd like to just sort of finish up there. I can see by the time now that we've sort of run out of time for a lot of questions. I don't know how you want to manage that, Tony.
That's fine, Paul, and thank you. We at the qiCommunity, we're into system responses. You found an identifiable and clear problem. Didn't blame the pharmacist, didn't blame the GP, didn't blame the patients, but rather look for a systematic approach built on quality and safety and QI techniques. So congratulations on that. Do you think it's at the stage, Paul, in your area where Mark won't have to drive 30 kilometres to get Claire's medications now? What's the uptake been like?
Well, we've redone that survey a few years afterwards, and we tripled the number of pharmacies that held the core medicine. So we were delighted by that. But in tripling, we actually went from 6% to about 18%. So to me, there's still a long way to go. Certainly when we look at the community pharmacies in the south of Adelaide, we're finding about a third of the pharmacies are holding these medicines. But that's anecdotal evidence. We'd really like to repeat the survey and see that we're on track with that. But yes, I would think that having 80 to 100% of pharmacies holding a small list of medicines will provide a great safety net for people like Mark, who are just in an awful experience of having to source these medicines.
And it does sound like a project for our primary health network, Paul, to engage with our pharmacies and GPs around this. Samantha's a community pharmacist from Canberra. She's tried to get her GPs prescribing in the manner that you've suggested with a defined list ahead of time, struggled to get their attention. Have you got any tips around that?
Yeah, a couple of ideas. I mean, we've certainly published our paper, our work around this so that we can actually hand the GP a peer-reviewed article around the issue. And that I think has helped move things forward. The other thing is not to be too harsh on the GP. So there may be some GPs out there who have got 20 years experience in prescribing in palliative care. and they may not wish to change their prescribing habits. They might be very comfortable, and from a safety perspective, you could argue it's useful for them to continue doing what they're doing, but just actually getting them to pick up the phone and asking them to have that conversation ahead of time with the pharmacy. But to me, it's about having that anticipating what is needed, and having that communication is really important at the outset.
So given that, starting with small steps, perhaps Samantha's may notice a patient getting medications in the early stages of palliative care. Maybe there's opportunities to ring the GP as a general reminder saying, do you think it's likely we should have in stock this range of items for the terminal phase, and are you happy with this range? Just local small steps, maybe a start.
Absolutely,
Okay.
and that's certainly what we would encourage our pharmacies throughout Adelaide to do. You mentioned the primary health network, and this is a really valuable opportunity, I think, for primary health networks to take up. In fact, in Adelaide, there's been some strong interest from our local a primary health network around this project, and seeing if we can put things in place to expand it further.
Excellent, Paul. I think our primary health network will be giving you a ring. So Sarah, thank you very much for organising. Paul, thank you for your detailed information, and we really, as I said, like your quality improvement approach to solving that issue. Thank you everybody for joining us. Sarah, what's up next?
Yes, thanks, Tony. So April's qiCommunity webinar will be on Tuesday, the 17th of April at 1 p.m. Eastern Standard Time, and joining us will be Dr. Lara Roski, and she's from the Victorian Cytology Service, and she'll be discussing the new cervical screening program. So I'm sure there's lots of people who will be interested in that. So please look out for our newsletter to register. Just to let you know, I have recorded today's webinar, and so I will be sending out the link to everybody who registered today. So if you think that this really fascinating topic will be of interest to other people, please feel free to pass it on once you receive that. So thank you again, Tony and Paul. That was brilliant, and I just really appreciate your time today.